I'm going to have you started. People will hopefully come in. This is Dr. Raju from Rain Center. He's going to talk about lessons from endovascular management of the lower extremity venous obstruction. Let's get started. 10 minutes late, so.
About 6 people here, and I can address you by your first name, I think, almost. Yeah. If Dr. Dake was here, I would express some words of thanks and gratitude to him. I think Dr. Arslan is walking over to the other side. Corral the stray bulls. If the crowd doesn't increase, we might as well move to the bar, and I think I can give my talk there over a beer. Dr. Arslan, ladies and gentlemen, since the crowd is small, I think I can say idiotic and provocative things and get away with it. Dr. Dake is not here, but I want to thank him for inviting me to this conference. And I also owe him an enormous debt of gratitude. He is actually the one who got me started on venous stenting. I sat there one time in Los Angeles, pioneered so many things, and he in fact is a leading pioneer in venous stenting. Listened to his lecture, that's what got me started. My experience is almost exclusively in iliocaval femoral disease, and we have accumulated a large experience, something like 2,200 cases up to date. This one was published about 5 years ago, and 1,100 limbs. The remarkable thing about stents in the lower limb is the astounding patency. This includes thrombotic as well as non-thrombotic, so-called primary disease, non-thrombotic as well as thrombotic disease patients. And up to 6 years, you can see the patency is 93%. In non-thrombotic cases, something like 600 cases included here, there's only 1 case of stent thrombosis in 6 years, and most of it on aspirin. So the patency rate here is simply astounding in the lower limb. The symptom relief is far too excellent. This is pain relief and swelling relief. That's also healing. Now you might think 58% is not great, but in fact it's one of the best cumulative healing rates with a variety of techniques used in the venous system. The more remarkable thing is lack of breakdown of the ulcers. Once they heal, is perfectly stable curve. The problem with disease, venous disease in the lower limb, iliocaval disease, is the poor sensitivity of radiologic diagnosis, which is, again, from what I gather, is what you are talking about in your own experience on CCSVI. You can see that there's a distal lesion here. There's a frontal projection. There's a distal stenosis. Up here it looks fairly normal, but you start rotating That's a 60-degree rotation, and you can see that there's a stenosis here proximal, and the distal stenosis has disappeared, which means these lesions are not circumferential, but anterior-posterior or medial to lateral. So venography, the sensitivity falls down. And this is what you would call a normal venogram in most places. Some translucency here, dilution of the dye. But on IVUS, even though the caliber here looks nearly normal, you can see a very tight stenosis. There's a 6 French IVUS catheter, so the lumen is hardly larger than the IVUS catheter. That's an artery crossing the vein right here, iliac artery. Here it's even more normal, and most radiologists would call it cold normal. But then again, on IVUS, it's a stenosed lesion. The normal lumen should be something like that, that is stented iliac vein. So that's a caliber you would expect normally. Now that's a focal post-thrombotic lesion, and it doesn't show up on venography. Focal lesions here are easily drowned out by contrast. And the poor sensitivity of venography in iliac vein lesions has been well established. Numerous series and papers on this going as far back as 1950, work by Dr. Negus, Cockett, and others. Now, stenting in the venous system is different than the arterial system. One thing that we found that you have to always stent these lesions. Balloon dilatation alone does not work. You can document it by IVUS examination. You can do IVUS, balloon dilate, look at the lesion again, it has totally recoiled. So first 20 cases that we did was balloon dilatation. It failed. Now we hardly ever do balloon dilatation alone, always stent. Different from arterial lesions where you have plaques, remodeling. Once you dilate an arterial lesion, I think it stays open for a reasonable period of time. Not the case in venous disease. And I have been listening with interest to balloon dilatation and CCSVI. And I have always wondered what is it different about CCSVI lesions. They are all collagenous lesions. How are they different from the type of lesions that we see? Now this is peculiar to the iliocaval junction. It's a choke point. You have to extend the lesion, stent into the IVC. And you have to use large caliber stents. Again, there's a problem jumping from the arterial to the venous side. The arterial side, you're worried about perfusion. So if you can open the stenosis somewhat, you are doing okay. But on the venous side, the aim is peripheral decompression, which means you have to put large stents, fairly approximating normal anatomy, to decompress the periphery. You have to stent all lesions without skip areas. Skip areas result in restenosis occlusion. And peculiar to wall stents, you have to have generous overlap, otherwise you might get gap areas with passage of time. For decompression, large stents, 22 millimeters for IVC, 16 for CIV, 14 for EIV, and 12 millimeters for common femoral vein are recommended. I just use 18 millimeter stents all throughout and dilate it to these various dimensions at various locations. And this leaves room for hyperdilatation later if you get compression, ISR, instant restenosis, and so on. And then IVUS is superior than venography for diagnosis, stent deployment, choice of upper and lower landing sites, and avoid intrastent abnormalities. So once again, the difference between arterial and venous stenting, two different systems, different flow patterns. In the arterial side, you are just opening the stenosis large enough to perfuse the peripheral tissues, but in the venous side, it's decompression, peripheral decompression. You want to lower the pressure. Sometimes 1 or 2 millimeters at the periphery, at the microcirculation, is all that it takes. So it's different. In the arterial side, Dr. Day could teach you perfect is the enemy of good, so don't go for perfect correction. Subtotal correction is fine. But in the venous system, you need to have perfect correction. If you don't correct perfectly, then you are not going to get symptom relief. Minor residual stenosis are well tolerated on the arterial side, not so on the venous side. You will get residual symptoms if you don't get complete total correction. On the perioperative care, bivalirudin or heparin during surgery, warfarin only for thrombophilia, recurrent and unprovoked thrombosis, but aspirin for all others. And I showed you the patency figures, especially quite astounding considering that's all you use for these stents. Duplex stent surveillance, 6 weeks and yearly. About 20% of all stents will require reintervention, dilatation, or add a stent above, below, etc. Not bad. This is a 10 millimeter stent. Somebody placed it within the iliac veins. It's grossly small. The upper end got constricted even below 10 millimeters to 6 millimeters or something and thrombosed. These are all one-shot deals. If you don't do it right first time, salvage is very difficult. This is also a 10 millimeter stent. Again, misguided based on arterial experience. They thought they were opening up something with a 10 millimeter lesion. Go for the smallest stent, I suppose. Didn't do the patient any good. It stayed open, but leg swelling symptoms persisted. This is a stent that was placed right at the iliocabal junction. For some reason, people are afraid to go into the vena cava. It doesn't work, especially with wall stents. It gets squeezed down, and there's recurrence of stenosis, as you can see right there with distal migration, collaterals. So we routinely extend these stents into the vena cava, and but then again, this is a situation peculiar to iliofemoral segment. Wall stents in the veins you can extend across joint creases with impunity. There is no fracture, no erosion, nothing. I mean, this is over 2,000 cases, and I think I had only one partial erosion through the vein, not into the artery, outside, and one fracture, which was due to a post-thrombotic situation. The bad things that happen when you cross the joint crease in arteries simply do not occur on the venous side, possibly because the fatigue fracture of constant arterial pulsations is absent. And this is ISR, you can see right here. But the incidence is much lower than in the arterial system. Arterial system, coronaries elsewhere are talking about 20-30%. But bad ISR like this is only 5%. And half of it is not true ISR. Half of it is simply layering, thrombus layering, not hyperplasia. One thing peculiar about venous stenting is stent compression that occurs. You can see the post-thrombotic fibrosis there. That was a 16 millimeter stent. In course of time, it has gotten compressed to something like 9 millimeters, half the original size almost, because of post-thrombotic fibrosis. If you put a large enough stent initially, you can go and hyperdilate these things and correct them. Again, a lot of concepts in the venous system all transposed from the arterial side inappropriately. As you well know, on the arterial side there is peripheral resistance. If you calculate it in terms of pressure gradient and flow, that will calculate out to be approximately 60% functional stenosis, peripheral resistance itself. So if you're going to produce a lesion here before the periphery, it has to be greater than this 60% to be flow limiting, and that's somewhere around 65–70%. That's what you call a critical lesion, right? I mean, you need a 70% lesion in renal arteries, lower limb arteries, before you get perfusion compromise. On the venous side, there is no parallel peripheral resistance. So what stenosis is required? And you're not talking about perfusion either. You're talking about an increment in peripheral venous pressure. How much stenosis do you need here to raise the pressure in the periphery? We don't know. There's no experimental work. But in practice, from clinical correlation, it seems to be somewhere around 40 to 50 to 60%. 50% median will produce peripheral congestion. Now, these lesions, iliac vein lesions, often called May-Turner lesion, Cockett lesion, etc., are present in the normal population. If you do an MR or CT, you can show that 60% of the general population, 60% in this room, will harbor a lesion like this in silent form, obviously silent. And but if you take symptomatic patients who have chronic venous disease symptoms, do an IVUS, you're going to find this type of lesion in 90% or more of symptomatic patients. These are characteristics of permissive lesions. That is, they remain silent, they occur frequently in the normal population, but something else happens to perturb the system, a secondary event of some type, then these lesions become symptomatic. The classic permissive lesion is PFO, 25% of the general population. So just because a CCSVI lesion occurs in the general population without symptoms, it doesn't necessarily mean that the lesion is benign. So this is, the human pathology is full of permissive lesions. So careful interpretation is necessary. And one principle of permissive lesions, you don't have to go after the secondary insult that precipitated symptoms. You can correct the permissive lesion, and in most cases, the symptoms would resolve. So the general principle is to attack the primary permissive lesion. There are a number of secondary insults that precipitate symptoms in May-Turner syndrome, trauma, infection, reflux, DVT, joint surgery, edematogenic drugs, numerous ones. I suspect you have similar stand-ins in CCSVI. Now, since it's a small group and I notice that you don't have stones to throw, I'm going to make some provocative statements. You can laugh me off the stage if you like. Now, in an erect individual, I'm sure all of you know, the jugular vein is collapsed up to the root of the neck. A physiologist has said that when primitive man tried to stand on two legs, he was attempting a feat of no mean difficulty. A lot of bad things happen to you when you stand up. You were not made to stand up, made to walk on all four or lie down, including collapse of the jugular veins. Just because this happens, it doesn't mean that it is innocuous. This is the famous tube law. A collapsible tube, if you collapse from external pressure, once it collapses down to two channels like this, two small channels instead of one big channel, even more extreme right here. And from your physiology guidance textbook days, you know the resistance to flow is to the power of 4, right? Radius to the power of 4. That's what the resistance is. So resistance to flow here is a factor of, it's exponential compared to here. Now this is a occluded iliac vein. These are large collaterals. They look impressive. In fact, these are so profuse, you think this patient should be okay, not symptomatic, but you put a stent in there, all these things disappear. They are still there. They disappear because you open up a low resistance flow. Now, a pathway for low resistance flow, and there is no need, and the flow will preferentially go through this wide channel rather than this multiple small channels. So I am suggesting to you that in fact when the man stands up and the jugular vein collapses, sure enough the drainage shifts to the posterior circulation, but it's a high resistance drainage. You will increase, you will decompress the brain if you stent the jugular vein in a normal person because it's collapsed. It has nothing to do if you have, we stand up 2/3 of the day, lie down 1/3 of the day, right? So as long as you're standing up, whether there's a lesion or not, it's a high resistance outflow in the jugular vein. Now on top of it, if you have a lesion, you are going to have high resistance flow standing up and lying down. So if you have stones, you can throw at me.
Thank you very much. Any questions from the audience?
Thank you, Reggie. I would like to know, in your vast experience, what is the proportion of intraluminal defect in the obstruction you find at the proximal level, and what is the proportion of reflux that you may find in the lower limbs due to primary venous obstruction?
If you take CVD cases, in about 30% you will not find any reflux at all, or trivial reflux. Single level reflux, which should be asymptomatic, or saphenous reflux, but the vein is very small. Basically too trivial to cause the symptoms. And that will be 30% of patients who have pure obstruction at the iliac vein level. The other 60% have significant reflux, but in association with iliac vein obstruction. It seems to be the case that the iliac vein obstruction, which was a permissive lesion, and you have little reflux, significant reflux, the patient becomes symptomatic. It's very interesting. You don't have to do anything to the reflux. You can just tend those lesions, leave the reflux alone, and patients, for the most part, will become asymptomatic with uncorrected massive reflux. So in the lower limb chronic venous disease, the whole concept has gone from correcting reflux to paying attention to obstruction.
Sal Sclafani, I enjoyed your talk. I had a couple of questions. What is the flow rate in the left iliac vein?
It's probably about 500 cc's a minute.
That much? Okay, thank you. And I had another question. You talked about asymptomatic and symptomatic patients with the disease. I guess because there are connections between the iliac system and the cerebrospinal system peripheral to the obstruction, there's at least a theoretical possibility that some of the flow would end up in the cerebrospinal venous circulation. And the other, so symptomatology related to multiple sclerosis, for example, or CCSVI symptoms, may be a symptom that would be an indication for the treatment of a stenosis of the iliac stenosis in an otherwise asymptomatic patient. That's a very controversial and difficult to prove situation at the current time, because the vein is the ascending lumbar vein is relatively small. I would like to know, how often do you see a large ascending lumbar vein coming off the iliac vein?
You see it all the time in total occlusions. Yeah.
Okay, and the other thing is I see these tremendous collaterals in the pelvis, and I'm wondering if any of those patients have the pelvic congestion syndrome that's described in women associated with rectal pain and other symptoms like that. How often do you see that?
Yeah, its a combination is not all that common. It seems to be two different subsets of patients.
Thank you.
Again. Now we're going to have Dr. Scalfani himself to talk about consequences of venous obstruction in other vascular beds.
Thank you. Well, that was very exciting, Dr. Raju. Hope you'll stay for my talk for a moment. I always disclose that I don't believe that I treat multiple sclerosis, that I'm not sure about that is a fact yet. I think I treat CCSVI symptomatology. I am salaried by a commercial firm called Fresenius Vascular Care, and they do treat CCSVI for profit. But otherwise, I have no financial relationships with any other providers of goods or services for CCSVI. The goal of this presentation is really to focus on those venous obstructions that have the potential to confound or impact on the chronic cerebrospinal venous insufficiency syndrome. And how could that possibly be? They can do it by causing obstruction of cerebrospinal veins. They could do it by redirecting flow from the non-cerebrospinal venous circuits into the cerebrospinal circuits. And they can confound the diagnosis of some symptoms by involvement of the peripheral nerves. These are the more common venous obstructive syndromes, and as I was given this topic, it was such a broad topic that I certainly could have spent the whole session on it. So I decided to focus on thoracic outlet, the Nutcracker syndrome, and the May-Turner syndrome. Unfortunately, I can quickly go through May-Turner syndrome to a large degree because Dr. Raju has already discussed it. The May-Turner syndrome is a compression syndrome, most commonly caused by compression of the left common iliac vein, and in many cases the I'm losing the word, but anyway, compression between the right common iliac artery and the lumbar spine, and frequently seen in overweight women, often asymptomatic, as was told. And the presentations are either acute deep vein thrombosis, swelling, varicose veins, and treatment generally is thrombolysis for thrombotic disease and stenting. But is there an association? And I've alluded to it already in my questions to Dr. Raju, but the association has been mentioned. It was mentioned in the seminal paper by Dr. Zamboni, but the real association is unclear. There's not been any really good data to show it, the incidence of association. And when you take a pathological or a quiet pathological state of a stenosis of the iliac vein of 60%, it becomes quite significant when we talk about patients with CCSVI, because the majority would likely have some evidence of obstruction, and then the question comes up as whether they should be treated or not. The Albany group did a study. It looked at their patients and found that the incidence of the May-Turner compression was not significantly different in the MS population compared to the general population. And therefore they recommended that we not look at that vein. But I think that conclusion doesn't really address the issue, which is not do they have a higher association, but does that association lead to additional symptoms? And we really should spend some time trying to figure that out, because I certainly don't have an answer for that. The left common iliac vein is connected to the cerebrospinal circulation through the left ascending lumbar vein. And from there into the lumbar veins and then into the vertebral plexus. So the flow in the cerebrospinal circuit can certainly be augmented by collateral flow going from the 500 ml per minute coming from the left iliac vein. Even a small percentage of that could be a significant augmentation of the flow within the cerebrospinal circuit. And if there's the presence of hypoplasia of some of those lumbar veins, it could really cause some difficulties as well. Also, continuing on, the ascending lumbar vein may continue as a large vein into the renal vein and can then extend beyond the renal vein into the hemiazygous system and have a secondary point of augmentation of flow that's not respective to the spine or even the thoracic cage and lumbar musculature. So this is the theory only, and hasn't really been proven. There have been some reports of neurological deficits associated with ascending lumbar disease. In this situation, a paper in a Chinese journal that I couldn't translate into an English title, they described 3 patients who had stenosis of the ascending lumbar vein, who developed imbalance and weakness, and were treated by angioplasty of that vein and had clinical improvements. And they are among other groups that have called this venous hypertensive myelopathy, but it may very well be multiple sclerosis of the spine, the spinal cord. So I think there are some serious questions that we should address over the next few years in analyzing whether this can have an impact. How we design those studies would be very unclear. Do we not treat this initially, see what the outcomes of standard treatment are, and then treat, or do we treat or not treat in 2 arms and see whether outcomes are improved? Those are questions that we have to design. The thoracic outlet syndromes are basically obstructions of neurovascular bundle as it exits or enters the chest. The majority of them are neurological, but 2 to 8% of these outlet syndromes affect the veins, and they are associated with thrombosis of the vein as well. This is called Paget-Schroeder disease. It's basically narrowing and fixation of either the axillary or the subclavian vein by scar, by muscle contraction, by ribs, accessory ribs or axillary bands, and the tethering of the vessel in an area of considerable movement leads to endothelial stress, intimal hyperplasia, ultimately leads to some fibrotic tissue, stenoses, stasis, and has the potential for thrombosis. Occasionally, those thromboses can extend into the jugular confluence at the inferior jugular bulb. And the question then comes up as if you have CCSVI involving the contralateral jugular vein and azygous vein, could that induce you to exceed the capacity to drain the rest of the normal circulation through perhaps a normal vessel that got involved? So that's one possible way that the Paget-Schroeder disease could worsen or bring on clinical effects of CCSVI. The treatment is not stenting, it's surgical decompression and bypass. The motion in that area is probably not a great area for stenting. So there are no clear-cut associations between Paget-Schroeder and CCSVI. However, one of the symptoms is migraine headaches, and perhaps that isn't a symptom of CCSVI. It's also been reported that the deep cerebral veins are dilated in patients with Paget-Schroeder disease. Of course, the compressive neuropathy could, peripheral neuropathy due to the compressions could confound the diagnosis of CCSVI and make it a little bit more difficult. So that's one thing to consider. I would say that the thoracic outlet syndrome can also result in collateral blood flow. That collateral blood flow can be redirected into cervical collaterals. Those cervical collaterals may be necessary for the outflow of obstructed internal jugular veins from CCSVI. So compounding that would be similar to the Therion-May-Turner syndrome, in which there was augmentation of flow going back up into the neck, and that could contribute to or make worse CCSVI symptoms. There is not much in the way of literature, and I have no personal experience to give you any guidelines on that, except that the possibilities exist. I do have some interesting anecdotal cases on the next one, and that's the nutcracker phenomenon syndrome. This is really an interesting one that's very important, in my opinion. The left renal vein is compressed by a number of mechanisms. Anteriorly, the left renal vein can be compressed between the aorta and the SMA. Posteriorly, if you have a retroaortic renal vein, it can be compressed between the aorta and the spine. And then there are some very rare compressions of the renal vein by the gonadal vein encircling and trapping the vessel, or having an aberrant right renal vein. The symptoms are quite protean, and they include hematuria, either microscopic or macroscopic, can lead to anemia, can lead to colic due to clot drops. Proteinuria can be massive, lead to orthostatic hypotension. Pain syndromes are quite common. Pelvic pain, rectal pain, flank and thigh pain are all associated with this syndrome. And very often some of those pain syndromes are because of the high flow in decompressing through the gonadal vein, leading to incompetency of the valves in those veins, leading to varicocele or the pelvic congestion syndrome in women. Hypertension has been reported, and chronic fatigue has been reported. I know we don't now no longer believe that chronic fatigue is perhaps not real, but that's probably the most common symptom in many patients. I think this is the most likely to impact on the renal vein for a variety of reasons. There are big collaterals. The flow is extremely high. The flow is higher in the renal vein than it is in the jugular vein by about on an order of 1.5 to 1. Two of the major collaterals connect directly into the spine, the hemiazygos and the ascending lumbar vein. Both are important collaterals. The gonadal vein, fortunately, I believe, is usually the one that's the most common, and perhaps that may reduce the incidence of contribution of CCSVI. Let me show two cases, and I think I'll leave it there because I think they do raise an alarm. The first was a 58-year-old woman, questionable whether she was relapsing, remitting, or secondary progressive, with blurry double vision, imbalance, fatigue, heat intolerance, some weakness in the extremities, and a changing EDSS that at the time when she went to India in June of 2010 was in the 3.5 to 4 range. She had angioplasty with a 14 millimeter balloons in both internal jugular veins, and the azygos vein was thought to be normal. And she had clinical improvement in those CCSVI syndrome type symptoms, but the relief was, as we hear not too uncommonly, 6 to 8 weeks, things gradually reverted back to their steady state, and she left India with a little bit of discouragement. She returned to me about 1 year later asking me to take a second look, and I fully expected to find recurrent stenoses of the internal jugular veins, and there were none. Not only was venography, as you see here, pretty normal, but intravascular ultrasound showed no occult intraluminal lesions like webs or septations or membranes or valve immobility. But she had the nutcracker syndrome. So I treated the Nutcracker syndrome with stenting, and her clinical symptoms improved significantly. On her follow-up visit to her neurologist, her EBSS was now 2. And this has been sustained for the last 8 months. And she's been very active, walking a couple of miles, very energetic. And so I think we have to be very careful of situations like that. So that shows a case of CCSVI that incompletely responded to jugular vein angioplasty, and that analysis of that renal vein was important in order to have full and effective treatment that's durable. This patient is even more interesting and more bizarre. This is a 47-year-old female professor who was diagnosed after several years with the pelvic congestion syndrome secondary to the ovarian vein reflux, ultimately found to be caused by the Nutcracker syndrome. This is her workup that occurred over 2 years, and ultimately in 2010 she was diagnosed. The diagnosis is clear here because of, you can see the renal vein crossing over the aorta is quite narrow, and you can see very prominent gonadal veins and pelvic veins throughout the pelvis here. She was treated at another institution in February 2011, and at that time they diagnosed the Nutcracker syndrome, and you can see the large gonadal vein filling large pelvic collateral veins, and the catheter was advanced deeply into the vein and treated as a standard treatment for ovarian varicocele and pelvic congestion syndrome by coil embolization with some Amplatzer plugs. And she had some improvement in her pelvic congestion. However, within a few days, she developed fatigue, weakness, imbalance, memory and cognition deficits that had never existed in her life. She had never been to a neurologist before. Not that I'm a neurologist. She had not had any neurological deficits, had no need for an MRI, nothing. So I saw her and decided that because she had symptoms of CCSVI, I would, of course, do ultrasound, and she filled criteria 1, 2, and 4. And that should have been a typo, 1, 2, and 3. And she had venography of the neck and the kidney done. And quite interestingly, she had a compressive phenomenon at the C2 level with very large condylar collaterals and a diverticulum on the jugular vein that on ultrasound, intravascular ultrasound, you can see is a septum dividing the jugular vein, and it extends down onto the other side, leading to a stenotic area that kind of follows this red line in this direction. She was treated by we did not treat the upper lesion, and we treated the lower lesion with large balloon high pressure angioplasty, and we think we had an improvement in the cosmetic appearance of this lesion. On the other side, we had similar findings, but much more exaggerated. Again, we had very large condylar collaterals extending down into the posterior cervical vessels, and you can see that there's really no flow going through this internal jugular vein. So pullback imaging eventually showed that part of the lumen was present but small, and that there was compression stenosis here and high-grade stenosis here, which we treated by balloon angioplasty. On the IVUS, you can see very, very slow flow here, and coming down to the pinpoint compression of the around the IVUS catheter, which is 2.6 millimeters. So you're seeing, that the vessel is at no more than 2 millimeters in diameter. So we treated it with balloon angioplasty with a relatively small and gentle angioplasty going from 6 millimeters to 8 millimeters, and we were unable to get this completely open. You can see the annular, you can see slight annular constriction still here, but I liked it to stop rather than over dilate this vein and risk rupture of the vein. This was her imaging in the abdomen and pelvis. This is her repeat venography. You can see on the renal vein that the renal vein has no flow. We have extensive collaterals coming from the renal vein up into the hemiazygos and the paravertebral plexus, etc. And there's reflux down contralateral side on the hemiazygos, on the azygos injection. And I think this one is a catheterization from above, from below the iliac vein, and you can see that there's a direct continuation upward. So the treatment here was to analyze. The IVUS clearly shows that there are webs and septations within the renal vein, common in this particular disease, and gradual compression to no lumen, and that this area corresponds to this area, and you can follow it here. You can see this webbing that's more in the hilar region, coming down to a tight narrowing as we reach the inferior vena cava. And we treated that with a double stenting and got really good flow. And you see there's no flow going into the cerebrospinal circulation. Within 24 hours, her mental clarity had returned. Her memory had improved, and she had energy, and her balance and strength had returned. We have referred her to a neurologist to see if she has MS, but the probability here is that this is temporally so related to the pathology associated with the nutcracker syndrome. I believe what's happened here is that by occluding the gonadal vein, all of the blood flow from the renal vein was then shunted away from the ovarian vein, down, up and down into the cerebrospinal circuit, leading to acute CSVI. Let me put it that way. I can't call it acute chronic cerebrospinal venous insufficiency, but I think that the message is there. So in conclusion, I would say that treatment of the internal jugular vein and azygos vein, or interrogation of those veins, may not be sufficient to flesh out all the potential causes of CCSVI or contributors to CCSVI. The fact that these lesions are so commonly seen, very common, both of these diseases, both of these stenoses are very common. And, in patients with CCSVI, I think we should consider them to be symptomatic nutcracker stenoses, so that they would no longer be called nutcracker phenomenon, but the nutcracker syndrome. And I think this is just a not recognized symptom, potential symptom at least, of the nutcracker syndrome. The diversion of the renal blood flow can be very significant, and I tried to find good data on iliac vein flow, but thank you, Dr. Raju, for giving me some reference that I can at least start to work with. That is also significant, and those flows are greater than the jugular vein, which is estimated to be about 350 to 375 or maybe even 400 ml per minute. So I think we have to do a lot to work on this. There's quite controversy in the interventional groups about whether this is necessary or not, and I think that's one of the reasons we haven't reached consensus yet. Thank you. Any questions for me?
Hi, Sal. Those cases are quite compelling, very revealing and impressive. And I'm, of course, out of Albany, New York, very supportive of every aspect of looking at CCSVI or CSVI, as you put it. But as a safety officer and person who's published on the safety aspect of it, I think we all have to still be aware that there are significant risks involved with taking that next step. And in just evaluating the treatment of this, we all know that May Turner and Nutcracker won't respond very well to angioplasty alone, angioplasty being much of a less of a risk in general than stenting. So I do still worry about the complications, and patients do need to know that going forward, that there is risk involved with the anticoagulation aspect, with permanent thrombosis of renal veins and leg veins, particularly if they were asymptomatic grade 1 or 2 May-Thurner syndrome. But we still do need to look at that because those cases cannot be ignored. Thanks.
Thank you.
Hi, Dr. Scalavani. That was a good talk. I was just wondering, you have two cases. One case there was treated for CCSVI in the neck, but didn't have any effect. And then after the renal, it was a renal vein or something, and that improved quite a lot. And the other case, you had both those, in the neck and the renal vein treated. So I was wondering, is there any connection between the two? And do you know which one is accounting for example, the second case, the improvement for the second case? Which part, whether it's the neck vein or the renal vein?
My logic would be this, that in the second case, we had bilateral stenosis of the internal jugular veins and no symptoms.
Okay.
She had excellent posterior drainage through the condylar vein to the posterior cervical vessels. I think it's very important to recognize that that was present, and that perhaps may have allowed her to go without symptomatology. However, what happened is that only after occlusion of the gonadal vein did she develop symptoms, neurological symptoms, which makes me deduce that the augmentation of the flow was sufficient in the presence of obstructions to overwhelm her compensatory mechanisms. And perhaps if she had azygous stenosis, she would have developed much earlier in her life spinal MS. But that's all I can do is give you conjecture.
Thank you.
Okay. So, I'm Bilal Tarslan. I'm from, I recently was at Tampa, right here next door, but started working on January 9th when this hospital opened up in Chicago at Rice University Medical Center. I have no relevant disclosures other than treating CCSVI. And I will try to stay on focus discussing other venous problems. Essentially, that's the goal of this session, and try not to get into the CCSVI as much as I can. I'll talk about other venous problems that we deal with on a routine basis, which are in general can be headed under multiple topics like thrombotic embolic, external compression, valvular dysfunction, aneurysmal dilation, device-related problems, or iatrogenic. Thromboembolic is the most commonly encountered problem, and the two major medical issues are deep venous thrombosis, which essentially involves lower extremity primarily, and upper extremity to a much lesser extent, or pulmonary embolism, which is a disease with fatal outcome as a result of DVT, and it results in 50% of mortality in these patients. DVT involves the lower extremity more commonly, as we said, high risk for pulmonary embolism. Management of uncomplicated DVT is easy. You just place the patient on anticoagulation if there are no contraindications. Complicated DVT often requires interventional therapies. Filter placement is still controversial, but if a patient cannot get anticoagulation or anticoagulation is not protecting the patient, then filter placement is a common practice. Also in patients who have very low pulmonary reserve and a repeat PE would be deadly, you should consider filter placement in those patients. In iliofemoral DVT, these patients are at very high risk for developing post-thrombotic syndrome due to incomplete resolution of the clot and valvular damage. So there's a register data. Unfortunately, there's no prospective trial in this either, and no one is telling us that we need to do a prospective trial. It is the standard of care right now. But the register data shows higher one-year patency rates with complete clearance of clot in iliofemoral DVT with catheter-directed lysis and stenting, and 72% of patients at 6 months have patency, with catheter-directed treatment versus 12% who are treated with anticoagulation alone. By the way, there is a trial called a ATTRACT trial that's looking into patients with acute DVT to compare if the management with catheter-directed therapies will actually do better than the ones who just get anticoagulation. And so consensus in DVT is to use strategies that increase the rate of clot elimination. So lytic agents, transport is rate limiting. In the arteries, you have a high-pressure system, so the lytic agent contact with the clot is faster and more. In the veins with a low-pressure system, it's relatively slower, and the veins are larger, so there are some problems. So incorporation of the mechanical devices, like the trellis device or the angiojet device, to disperse the lytic agent into the clot, and using earlier stenting techniques will improve the duration of treatment as well as safety of these procedures, because you don't want to leave somebody on TPA for multiple days on a routine basis. So the goal is to do this faster and safer. And when you use angiojet thrombectomy device, which is also called PASES, and TPA and stenting, about 43% of the patients will complete treatment in a single visit. Of these patients at 12 months follow-up, 83% of them will have a patent vein with no DVT, and their quality of life is like 67% of them with no pain and swelling. There's a newer technique that we use. We use the thrombectomy device to disperse the TPA into the clot with a very high pressure. It's called power pulse spray PASES. So when you use this technique, combine it with TPA and stenting, 67% of the patients complete their treatments in a single visit. Mean time for the procedure was 3.25 hours. I think it's better right now with more experience. We're getting faster in these things. In my practice, average duration is about 1 to 2 hours for treating these patients in a single session. So this is a case that demonstrates a clot in the IVC extending into the common iliac vein completely, internal iliac vein. And same patient, access was gained to the posterior tibial vein. And the venogram demonstrates essentially clot all the way from here up to the popliteal and superficial femoral veins. This is after lysis and power pulse spray of the TPA. As you can see, almost complete normalization of the popliteal and superficial femoral veins. Same patient, the common iliac vein is compressed, just like my other colleagues talked about this a lot already. I don't think we need to kind of go over and over, but after stenting, it got significantly better. This is IVUS imaging prior to any treatment, demonstrating clot at the common iliac vein level. Subsequent to lysis, clot is gone, but it's very tight and compressed. And after stenting, it's looking much better. And this is the patient before and after. Before and after. So this is another case, a 32-year-old man with history of IVC filter and coagulation problems, anticoagulated, but there's a chronic clot involving the superficial femoral vein. There's an evidence of acute DVT involving the iliocaval veins extending all the way into the IVC. And there's a Venous filter, as you can see. And this is after thrombolysis. The iliac veins opened up, but the IVC is also still almost occlusive. Not great flow. If you leave it like that, it's going to rethrombose. Additional 30 hours of TPA with bilateral catheters. Improvement, but still significant amount of clot involving the IVC. So in this case, a stent was placed through the filter and balloon dilated, and this is final flow. In cases like this, whenever I can, I now use actually covered stents, like endograft components, because we did have a case that when you have a lot of clot and you smash that with a balloon, they may break up and go through the stent interstices and cause a pulmonary embolus. So there's also debate regarding if you should place a filter on these patients prior to any such interventions or not. We used to place a filter on a routine basis initially, but we elected actually not doing that unless there was specific circumstances. And same patient 9 months later, still feeling better, but intermittent mild leg swelling, and the veins are open, bilateral open. There is some stenosis at this level, but he was fully anticoagulated and was elected to continue to follow him up at this stage because his symptoms were too mild. So what about upper extremity? The importance of upper extremity is increasing. Potential for significant morbidity. About a third of these patients will have pulmonary embolus, and they will present with persistent upper extremity pain and swelling. SVC syndrome is part of it, and it'll also result in loss of vascular access, because if you don't have any veins to get into, you'll have difficulty in treating patients for other disorders. And upper extremity deep venous thrombosis mostly refers to involvement of the axillary and subclavian veins. It could be primary or secondary, acute or chronic. The primary etiologies, this has been touched before, so I'm going to go quickly as much as I can, is effort thrombosis, also known as Paget-Schroeder syndrome, or idiopathic. There are patients who come with upper extremity thrombosis with no underlying disorder or no evidence of Paget-Schroeder, but they still present with thrombosis of the upper extremities. Secondary causes are central venous catheters, pacemakers, cancer, or post-surgical. So there's a paper published in British Journal of Radiology that they looked at patients who had PICC placement, and 38.5% of their patients had thrombus formation after PICC placement. And about 85% of these patients did have complete occlusion of the vein, segment of the vein that the PICC was placed. So for interventional radiologists who routinely do this all the time, it's becoming like almost like IV access procedure. Not really, when I was trained, I was told that you need to have it at least 2 weeks, up to 3 months or so duration to place PICCs. Now wherever I go, we get PICCs just for venous access for a difficult patient, which should not be lightly taken. I think we should review our practices regarding PICC placement. So there's two main types, axillary and subclavian vein thrombosis versus thoracic outlet syndrome. We need to be able to differentiate that, because the treatment is completely surgical in thoracic outlet syndrome versus it could be just interventional in the any other thrombosis scenarios. Axillary subclavian vein thrombosis will present with different sets of symptoms versus thoracic outlet syndrome. The best way to differentiate them is to do a Adson maneuver during a venogram. What it means is when you do the venogram on the normal arm abduction position, the vein will look relatively better, but when the arm is abducted all the way, the vein will be significantly compressed. Imaging modalities for this disorder, just like any other arterial or venous disease, you can use ultrasound, CT, MRI, or conventional immunography. Again, management includes multiple levels, from medical, limb elevation, compression with an arm sleeve, anticoagulation, to interventional therapies with thrombolysis, thrombectomy, and surgical. Angioplasty and stenting, depending on the etiology of the disease. And if it's a thoracic outlet syndrome, obviously it has to be a surgical revision of the area for decompression. So this is a patient that slide that I received from Dr. Dake. It's presenting with swollen face and distending neck veins after 10 days post heart and lung transplant. This is the bilateral venogram. As you can see, the SVC is probably occlusive. There's some faint contrast in the brachiocephalix, most likely primarily thrombosed. After thrombolysis and stenting, significant improvement in the flow. And this is patient afterwards. So how about pulmonary embolus, which is kind of the end result of the clot formation elsewhere? there's been a large review of catheter-directed pulmonary embolus treatment by Scaff et al., published at American Journal of Cardiology, 348 patients. Techniques were different. There was no consensus on how to treat this. There is still no consensus on how to treat it. Some people will go in, put lysis catheters. Some people will do thrombectomy. Some will pulse spray. There's a wide variety of approach in treating this problem. And depending on the patient population, outcome can be really poor or relatively better. So selection of your patient is important. And clinical success in this paper was about 90% with a major bleeding rate of 2%. So this is just a case to demonstrate that a significant clot in the pulmonary arteries with less perfusion of the lung. And this is after 16 hours of lysis. Again, there's almost no residual clot left. I'll also touch a little bit about the chronic pelvic vein, even though it's not always an occlusive scenario. I think it is kind of related. It's like I just want to show that there is a venous disease everywhere in the body except the head and neck. And so it's a diagnostic dilemma. The management is challenging. Definition is pain more than 6 months that localized to the pelvis and is of sufficient severity to cause functional disability or lead to medical care. So this is actually from guidelines from the obstetrician and gynecologist society. And if you look at the gynecological conditions that may cause or exacerbate chronic pelvic vein by level of evidence, and level A is the one that is actually most accepted, B, C. If you look at it in the level A group, pelvic congestion syndrome is well accepted as a cause of chronic pelvic pain. So it was first described in, varices were first described in 1857. First association was made with the pain and varicosities in 1949. In 1984, pelvic congestion syndrome symptom complex was defined. Since then, it remains obscure and poorly understood. Some surgeons treat it surgically. We have been lately treating more and more of it as endovascularly. And it's seen more commonly in patients with reproductive years, 20s, 30s. Dull, aching, often unilateral, worse when standing and walking, plus or minus dyspareunia or postcoital ache. And anatomic considerations are important in the pelvic congestion syndrome. Obviously, drainage is through the ovarian veins bilaterally. And you can see the relation of the nutcracker syndrome in the scenario with the pelvic congestion syndrome. And common and external iliac veins also provide drainage. So they may contribute to the pathogenesis as well. So pelvic veins that are larger than 5 millimeters usually used as kind of an indication that there is some sort of congestion problem. Poor venous drainage obviously is helpful in diagnosis, and incompetent ovarian veins as well as reflux will also be a major part of it. Etiology is poorly understood. It's really, sorry. Okay. Etiology is poorly understood. Just like anywhere else, and it just makes sense though. Most of the time that we have a venous problem, it's usually either your valves are not functioning, if there's some sort of compression on the vein, or tumor, or another vascular structure. So it's all pretty much the same. It's just that we are too early in learning and really fully understanding veins, so we're just putting what we have together. It hasn't been standardized or well established yet, but we're in the process. In the females, though, also hormonal effects resulting in venous dilation has been suggested, and also vasoactive mediators were blamed to potentially cause pain. So this is a demonstration of a patient with pelvic congestion syndrome. You can see multiple varicosities in the pelvis on bilateral sides. This is an MRI demonstration, again, multiple veins, congested veins. This is a venogram. You can easily see catheter is inserted into the ovarian vein through the renal vein. And you can see the filling of the iliac veins. When you inject into the ovarian vein, hopefully you expect the flow to be one direction. But in this case, just like we see in some of the CCSVI patients, you inject left jugular vein, it drains from both jugular veins. Oops. Okay. All right, we'll go to the next one. I'm going to try to get to the treatment. Treatment for this is essentially embolization and stenting when necessary. It's becoming the treatment of choice. As I said, surgeons have been treating this surgically for a while. Embolization and stenting is minimally invasive, and you don't have to worry about the uterus and ovaries. They remain intact. Results are favorable. And published studies, which are still limited, there's no randomized trial to my knowledge, but retrospective reviews have been demonstrating very favorable results. Recurrence is rare at 5%, and about 80 to 85% of the patients improve pain. This is a 32-year-old female with hematuria and pelvic pain. And in the same patient, you can see the aorta and the superior mesenteric artery compressing the renal vein in 2 subsequent sessions. This is the venogram of the same patient. Contrast injection, nothing is passing through into the IVC as it should, refluxing into the kidney as well as down this way, which the ovarian vein is embolized at this time, so it's not going towards the pelvis. But if it wasn't embolized, you could imagine that a lot of pressure will be down towards the pelvis. So in this patient, venogram was obtained, stent was placed, and after stent placement, excellent flow. So in conclusion, venous disease has been a major medical problem, and it's well recognized by many specialties. There's no question or argument that it exists in the legs, in the liver, kidney, upper extremities, pelvis, anywhere you can think of, you have a vein, you may have a disease of that vein. It could be valvular dysfunction, it could be compression, it could be thrombosis, but it cannot happen above the neck, if you get my point. Okay. Yes?
How common is venous disease?
It is, I don't know the regular incidence, but let's put it this way. It's not as common as arterial disease, but I treat 2 to 3 venous patients a week. If you exclude dialysis patients. With dialysis patients, it is actually very common. It's probably every other dialysis patient is going to end up with having some sort of venous disease. But it's primarily iatrogenic. Patients with cancer, they will have venous disease because they'll have compression of their veins at some point. It's more common in cancer patients. They also have high risk for clotting. And in our world, it's quite common. I can't give you an exact number.
Is it possible you're underdiagnosing it, you guys?
Definitely. And we're only treating the ones that are coming in with very severe symptoms. I'm sure there's a lot of patients out there walking with valvular insufficiency or some sort of bad venous flow. They're just not to the level that they seek medical care, and there's no way to diagnose them.
No screening test?
Well, screening test for lower extremity is essentially, it's interesting you asked that. For lower extremity, it's ultrasound. It's pretty effective, pretty sensitive, and because you're looking for clot, not the actual CCSVI kind of phenomena. But for liver venous congestion, we do biopsy, and it goes to pathology, and the biopsy tells us if there's a venous congestion. You can also do a venogram at the same time to demonstrate, but it is hard to diagnose. So,
I was wondering if you know or are aware of any gender differences just generally with venous disease?
It's more common in females, pretty much lower extremity disease as well as pelvic congestion syndrome is essentially primarily female disorder. Something similar to that seen in males is varicocele, so it also happens in males, but to my knowledge, most of the venous disease is more common in females.
Bulent, excellent talk, and I totally agree with Dr. Hubbard. I think that venous disease is underdiagnosed. And one of the main problems that we have as physicians is that patients with venous problems and symptoms related to venous problems are commonly dismissed as either non-existent, non-important, or psychological. A lot of and this is particularly true with pelvic congestion. A lot of the women with pelvic congestion syndrome are considered to be having psychological problems, and they are dismissed as those. So pelvic congestion is actually one of those entities that is, in my opinion, significantly underdiagnosed.
I completely agree with you, and there may be a reason for that. If you have a constant pelvic pain in your life, it may drive you crazy.
The quality of life of these patients is actually miserable. And if you treat it, their quality of life improves in a significant fashion.
Thank you. Great. Dr. Randall Benson?
Okay. And Dr. Hubbard, thank you for that critical segue right there. I'm another neurologist in the group. I feel like I'm at Alcoholics Anonymous here, admitting that to you. And I've known Mark Hakey for about 10 years. That's my other disclosure. And I can tell you, as a neurologist, thinking about the veins is something we do when we need to put an IV in somebody. Occasionally with an OB patient, a pregnant patient, we try to rule out dural sinus thrombosis. But for 2 years after meeting Dr. Hakey, and Mark was very interested in working with the neurologists at Detroit Medical Center, and I said, Mark, and Mark, this is true. I said, you really ought to emphasize the arteries more. And he said, in so many words, I've done that. I invented MRA. It's time to move on. And so it didn't take long before I realized the importance of the veins. I mean, certainly we heard about functional MRI and the BOLD response, and that has spawned lots of laboratories and lots of interest. And Dr. Hubbard has built his laboratory around it, and it has very, very important implications, I think, for disease in general of the central nervous system. What I want to talk about today, another disclaimer, that I've treated this condition, pseudotumor cerebri, otherwise known as idiopathic intracranial hypertension. I haven't done work in this area. But what we're looking at are these sort of outlying disorders that may have venous underpinnings, and so I think that there's some pretty compelling evidence that IIH or pseudotumor indeed has quite a relationship to CCSVI. And I can tell you that this is a very unusual kind of disorder with no known cause. It tends to affect females largely who are overweight, sometimes morbidly obese. And the interesting thing is that probably the best treatment for this disorder is weight loss. And it works fairly well, not always, but frequently as well as the pharmacologic agents. And one of them is acetazolamide, and that decreases spinal fluid production. Lasix is another one. So what is this? Well, it's a disorder that involves elevated intracranial pressure, usually occurs in obese women in childbearing years with no identifiable cause. So it's idiopathic by definition. Symptoms include headache, pulse synchronous tinnitus. So that's a tinnitus that tends to resonate with the heartbeat or the cardioballistic pulse. They have transient visual obscurations and visual loss. Signs on examination, papilledema, or a swollen optic nerve head with associated loss of vision. Major morbidity, really the only serious morbidity is blindness or visual loss from papilledema. If you look at a scan, the ventricular system is not enlarged. Some reported that it was small, but that really hasn't been borne out. And you find increased spinal fluid pressure. When I should add that this is probably one of the few groups of patients that actually come in the door asking you to do a spinal tap on them. In fact, I can't think of another disorder where patients literally will beg you to insert a spinal needle, a large 18-gauge spinal needle, into their spine. What other findings do you see? Well, you see on scans, you see an empty sella syndrome. Frequently, you see a lateral sinus collapse, transverse sinus collapse. You see smooth-walled venous stenoses, flattened globes, and a fully unfolded optic nerve sheath. It's idiopathic, as I said. No other cause can be found. If there's another cause found, then it's secondary intracranial hypertension. Okay, what are the symptoms? Well, interestingly enough, headache is not really that different in these patients than normal controls. Transient visual obscurations due to pressure on the optic nerve head from increased intracranial pressure is common. The tinnitus, that is something that's not talked about very much, but patients will tell you ad nauseum about how bothersome it is. Photopsia, so they'll see spots, they'll have transient visual obscurations, and some will have eye pain. The incidence in the general population is about 0.9 in 10,000 persons, but it's about 3 times that, 3.5 times that in females between the ages of 15 and 44. And interestingly, it's increasing in incidence in parallel with the current epidemic of obesity. In obese women, aged 20 to 44, who were 20% or more over their ideal weight, the incidence of IAH is about 19 per 100,000. So there's clearly a relationship to BMI or to weight. More than 90% of IAH patients are obese, and over 90% are women of childbearing age. All right, so there's certainly an age and sex predominance here. Pathogenesis, spinal fluid is produced in the ventricles. It's filtered through the arachnoid granulations into the venous system. Any disorder that causes a reduction of flow through the arachnoid granulations or postgranulation obstruction in the venous system all the way to the right heart can lead to intracranial hypertension via a backup of fluid and pressure. Arterial venous malformations or dural fistulas with high flow, so not an obstructive mechanism but a high flow mechanism, may overload venous return and result in elevation of intracranial pressure. Okay. And just to give you an idea of the anatomy here, for those of you who aren't familiar, so we have the spinal fluid in the subarachnoid space, and we have these outpouchings called arachnoid granulations that filter spinal fluid into the venous system, and these dural veins lie in this potential space between the two layers of dura, except where these veins exist, and that's a true space. So what are the causes of intracranial hypertension? So we know what idiopathic means. Secondary causes, and they have been identified. High-dose vitamin A treatment, long-term tetracycline antibiotics for a variety of skin conditions. Hormonal contraceptives can do it. Other diseases or disorders, obstructive sleep apnea. Then you should be thinking about neck pressure and transmural pressure on the cervical veins when you think of obstructive sleep apnea. Systemic lupus, possibly mediated by scarring or inflammation of the arachnoid granulations. Chronic kidney disease, Behçet's disease, relatively uncommon disorders. So how do you make the diagnosis? Diagnosis is suspected on the basis of history and exam. On exam, when you do an ophthalmoscopic exam, you see a swollen optic nerve head, and I'll show you what that looks like. To confirm the diagnosis, because at this point, you're suspecting that there's intracranial pressure increase, you don't necessarily want to immediately do a spinal tap because conceivably, if there is a tumor there, you could actually induce herniation. So we get brain imaging at that point. Imaging should essentially show no explanation for the raised pressure. So you got to do more investigations. If the history is not typical, or the patient is more likely to have alternative problems. Children, males, the elderly, or women who are not overweight would raise the suspicion that there may be a secondary cause and that it's not typical idiopathic. All right, so here's a picture of the retina with the optic nerve head right here and vessels, both veins and arteries. Okay, and you have spinal fluid in the arachnoid here. And when there's increased pressure, then that pressure is exerted on this optic nerve right here, and that will cause a decreased venous return, ultimately leading to this picture. So here's normal, nice crisp demarcation of the optic nerve. You see good vessels. Now with increasing severity, you begin to see blurring, and you start to see these sort of halos around the optic nerve until finally you can't find the fundus or the optic nerve head at all, and you start to see a decrease or a cessation of spontaneous venous pulsations. And in that situation, you have a patient with florid papilledema who probably is not seeing very well and who may be blind. Now, how about similarities with CCSVI? Focal stenosis in the dural sinus, outflow has previously been demonstrated 30 to 93% of the time in these patients. These stenoses characteristically occur in the transverse sinus and frequently at the junction between the transverse sinus and the sigmoid sinus. They're likely due to, or possibly due to, hypertrophied arachnoid or Paconian granulations in most instances. There's increased evidence that in some patients increased intracranial pressure is caused by venous outflow obstruction due to these lesions. All right, so there's a very recent paper that also reviews the literature on the topic by Kumke et al., Journal of Neurosurgery, just a few months ago. So their objective was to define the clinical, angiographic, and hemodynamic outcomes of placement of unilateral dural sinus stents in IAH. And they looked at 18 consecutive patients with a clinical diagnosis of IAH. 88% of their patients were overweight or obese. There was a somewhat of an age disparity where the males were older than the females. All patients had papilledema. 17 patients had elevated opening pressures at lumbar puncture. In truth, one did not have a record of the spinal tap opening pressure. 12 patients had opening pressures of 33 to 55. And we generally consider 200 to 250 to be the cutoff. So these people had very high opening pressures, which supported their symptoms. All patients underwent diagnostic angiogram that showed venous outflow compromise. By filling defects, all patients, filling defects in the transverse sigmoidal junction region. Unilateral stent placement was used in the transverse sigmoid junction. Patients underwent intracranial selective venous pressure measurements. They got follow-up arteriography, 16 of them did, along with venography and venous pressure measurements. All scans showed filling defects in the transverse sigmoid junction regions. However, 7 patients were interpreted as normal initially by the clinical radiologist, with no mention of their filling defects. This was because the defects in the lateral sinus region, as has been alluded to, are common and most likely, similar to the jugulars, there's a positional dependency. Imaging and venograms revealed a high rate of asymmetric lateral venous systems in 12 of 18. So you had a dominant and a non-dominant, or maybe even an atretic system on the other side. All patent transverse sigmoid junctions had a filling defect with the deep drainage going toward the non-dominant side. All right, and just to show you what these arachnoid granulations can look like on a CT, contrast-enhanced CT, you see these paired, right, these bilateral arachnoid granulations in the transverse sinus. Here's the same patient with gadolinium-enhanced MR. Here's a time of flight MRV showing a partial stenosis here. Now, I should mention this is not from the same paper, but I just wanted to be able to demonstrate to you how these arachnoid villi can at least partially stenose these vessels. All right, and what they found, looking at the pressure gradients before and after their stent placement, you see high pressures, and at last follow-up, which varied, pressures were much lower. Okay, and our group at Wayne State, through Dr. Hakey, has collected a significant number of IIH cases, and so I want to now give you some case examples of some of these patients that fulfill the criteria. So here's a patient with transverse sinus stenosis here. Okay, now these patients, as far as I know, have not been treated. But what we're interested in here is the association of venous stenosis with the clinical condition. All right, and so as you can see here, there is reflux, I believe, Yeah, this is the right internal jugular here. Okay, so we have an abnormality in the jugular, and in the same patient, a gross abnormality in the transverse sinus system. This being the right transverse sinus right here. Very little flow, not surprisingly, in the left transverse sinus. Another case here, 35-year-old right IJV shows stenosis at the C2-3 level. Left internal jugular has diffuse stenosis. Okay. Very low flow. There's enlargement of the vertebral venous system. You can see all of these vessels here. And the right transverse sinus is right transverse sinus over here versus the left transverse sinus showing very, very low flow and probably not adequate flow even in the right transverse sinus. But again, you're seeing reflux in the right transverse sinus. And another case, again showing transverse sinus in combination with an asymmetric, mildly abnormal jugular system. All right, you know, at least in our experience, it may not be solely a problem with the transverse or lateral sinus. There may be additional stenoses or abnormalities that reduce the drainage. All right, so outcomes from stenting, papilledema resolved in 15 of 16 in Kumke's trial, and it has not recurred. All right, so 94% resolution of the chief morbidity, which is visual, and the overt sign papilledema. Visual acuity remains stable or improved in every patient. Headaches improved in 8 of the 10 that had headaches. The females tended to have headaches. The males tended not to. Authors believe that when the stenosis is elongated and smooth, it's probably collapsing under increased intracranial pressure. The more acutely marginated stenoses have intraluminal cause, possibly swollen arachnoid granulations or some of these other webs and things. They think that bilateral stenoses at transverse sigmoid junction or unilateral hypoplasia and a patent but stenotic vessel on the other side is an indication to image and possibly for intervention. They advise that diagnostic angio and manometry are useful techniques and provide important information to allow you to monitor the results of the intervention, and they certainly advise looking at pressure gradients. Now, editorial commenting on those findings by the chief of neurosurgery at Oregon Health Sciences says filling defects are relatively common in the transverse sinus as measured by CT venography, about 24%, which is pretty high, or MR venography, about 13%. But in the context of papilledema and a suspected diagnosis of IIH, these defects may assume increased significance. So that's what we've been saying all along, that in the right clinical context, there's an indication to go further. There may be a complex interplay between body mass index and venous sinus stenosis, in which the former compounds the latter, resulting in a clinical syndrome of IIH. If papilledema is detected, then CAT scan or MR venography should be completed. If stenosis is detected, the patient should then undergo diagnostic angiography with manometry. If a filling defect is detected with a pressure gradient of 10 millimeters or higher, stenting of the defect should be undertaken. Okay, so that was a pretty strong statement as recently as December of 2011. conclusions, a certain proportion of IH seem to have venous hypertension, which is treatable with stenting, and thus, in reality, should not be considered idiopathic, since a cause would be found. These are refractory to medications, and sometimes even refractory to optic nerve sheath fenestration, or basically cutting open the optic nerve sheath to decompress the optic nerve. Papilledema and visual complaints are markers, not headache, for this type. Need to make sure that the radiologist looks carefully at the lateral sinus system, since they may consider transverse sinus stenosis to be a normal finding. A pressure gradient of greater than 10 millimeters across a filling defect may predict a good response to treatment. And thank you for your attention.
We'll take one question.
That we don't really know what normal pressure, CSF pressure is. You know, it's either really high or it's normal. I've been worried that someone's going to ask me to do spinal taps before and after venoplasty, but now I think you can do it instead.
Thank you very much.
All right. I don't know if our last speaker is here, Dr. Kuchusa.
Nicholas can't make it today, so luckily we have lunch.
Exactly.
And we will be back here at 1 o'clock for the next session. Thank you very much.